I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
This is a hearing about the government licensing the electrocution of people to cause grand mal seizures. Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
It has no pejorative connotations. Have the first slide, please. I only want to talk about one anecdotal report because I feel we heard a lot yesterday of these sorts of accounts. I mention this one because it's now required reading for our residents. It's an account from a Dr. Gray, who was a neuroscientist, who had a severe unipolar depressive illness. And I mention it because it's written up in a reputable journal, and he had no difficulty in getting it accepted in that journal. And because it is critical of a number of aspects of psychiatry and the way psychiatrists proceed. It's critical of the psychotherapy that it's critical of the which he was treated in a psychiatric ward. It's critical particularly of cognitive therapy, which he felt was a co-emotional and largely trivial sort of treatment. But it's not critical of ECT. He was very frightened when he had his first ECT, but very clear that it helped him and didn't affect his. And all trainee psychiatrists should read it and experience what it's like to have a serious melancholic depression and have people trying to make you better in a way that can be really very, very painful. Now, there are large anecdotal reports in the literature. I clearly admit that the negatives markedly outweigh the positives. There are many, many more statements criticizing ECT than there are praising it. But there are a few in the literature of patient objective saying that ECT help. As far as systematic studies are concerned, patients they think of ECT. There are very few in the literature, and I find this surprising. I find it particularly surprising that there is no American study. Nobody in this large continent has bothered to ask patients what they think about the treatment in a systematic way, and I find that frankly amazing. This first study is a small one. It was carried out in America by Hillard and Folger. It was carried out in North Carolina. These two doctors were not shock doctors, and they were really looking at the placebo effect of ECT, and they wanted to try and find out whether ECT would be experienced as working better or more powerfully in a ward where it was used very frequently as compared with a ward where it was used at a low rate of frequency. And they compared a high user of ECT ward and a low user of ECT ward, but on quite small numbers. And their conclusions supported their premise. That is, when patients were being treated in a setting where ECT was the main method of treatment, where it was almost expected that you got ECT, patients viewed the treatment more positively, they felt it made them better more quickly, than in a ward where ECT was an exceptional treatment, where it was used only on more severely depressed or selected patients. And their argument behind this was that this was not a specific effect of ECT, this was an attributional effect. This was patients being made to feel that ECT was a powerful and effective treatment, when in fact it wasn't. This is the study that we carried out, and there is another very similar study that our reporter carried out in the UK as well. We looked at a whole year's cohort of patients who had had ECT in the Royal Edinburgh Hospital. It's a mental hospital serving a catchment area of about 1 million people. There is no other mental hospital in that area. There is no possibility for private psychiatric treatment in that part of the UK. Anybody who has a depressive illness which requires admission to hospital would come into that treatment facility. And we surveyed people a year after they'd had their last course of ECT. By this time, most of them were out of treatment and no longer had contact with psychiatrists. We also looked at a small group of people who had had ECT more than 5 years ago because we wanted to see if the distance in time in the treatment lessened the impact of the treatment on patients' feelings and attitudes. This is the experience that these patients have had. You can see that in their lifetime, these are not courses of ECT. The 1971 group had about 18 ECT on average, and the 76, 16 treatments on average. But the range was quite large. There was no one who had hundreds of ECT treatment. The highest was 75. That time, in this particular hospital, most treatments were given bilaterally. That's not the case these days, where in the UK, the majority of treatments are now given on a unilateral basis. We asked patients with a semi-structured interview to come back up to the hospital and tell us what they felt. And these are some of the responses that we got. I don't have time to go into all of them. Only 16% felt very anxious when they were told that they had to have ECT. And nearly a quarter actually felt reassured that now something positive was being done. One very worrying finding was that half of patients were absolutely sure that they had been given no explanation whatsoever about the treatment. I found this particularly worrying because a number of these patients I had treated personally, and a number had actually been in a controlled trial that was reported yesterday, where a very long, informed consent procedure was required by the ethics committee. And it seems to me that this is why I'm sure Dr. Roth will touch on later this morning. The whole issue of informed consent, I think, has to be looked at again as far as ECT is concerned. When you're using an amnesic treatment, is there really any point in going through the same sort of consent procedures as you go through for other treatments, when half of patients can't even remember that procedure 1 or 2 days later, and certainly not a year later? It's now routine in our hospital for residents to go back to patients immediately after a course of ECT and at the first follow-up appointment and explain to the patient again why they had ECT, what the indications for it were, and what the side effects were. And that is a requisite that we have all our trainees. Interestingly, we didn't find that anyone felt they'd been misled. No one felt they had been given a misleading explanation of the treatment. When we asked them if it helped them, you can see that 78% of patients altogether felt it helped either a lot or a little. And this fits with many of the controlled studies which show response rates of around 70 to 75%. Very few patients felt that it made them worse. Only one patient felt damaged in the way that the patients who were talking yesterday felt. This was a young man who was an electrical engineer. He had a previous diagnosis of schizophrenia. He had a very healthy respect for electricity, and he was absolutely convinced that ECT had damaged his brain, and he had never been sane since. However, although 78% of patients said that ECT had helped them, only 64% at that time said they would have the treatment again. And the main reason for this was because of the side effects. There was a very high rate of memory impairment in these patients. Overall, over 70% of patients feeling that their memory had been affected, and 20% feeling that it had been affected permanently. So, although many patients felt the treatment had helped them, for about 15 or 20%, the cost-benefit ratio was clearly in favour of not having the treatment again because of the side effects. But nevertheless, 64% said that they would have the treatment again. We asked about particular items in the ECT package, and you can see here that none of them particularly stand out as being very unpleasant or particularly pleasant procedures, except perhaps the feeling of falling asleep. Perhaps when you're deeply depressed, having space and time away from that distress is a pleasant sensation. We also asked about worries and fantasies about ECT. And again, fairly low rates of reporting. Not many people were worried about brain damage. Not many people were worried about the passage of a fit or having electric current. One point that I would make is that although those figures there of 9 and 7% for losing control, that was something that a small proportion of patients were very, very afraid of. The fear that they would embarrass themselves, that something terrible would happen whilst they were unconscious on the table, that they would urinate, that they would disgrace themselves in some way, was something that I think patients need a lot of reassurance about. When we asked in this, later on in the questionnaire, 85% in a general sense said that ECT was a helpful procedure, only 7% felt it dangerous. When we asked them to compare how frightening it was with going to the dentist, this was not for an extraction, this was just for a checkup, 50% of people said that a visit to the dentist was a more terrifying and frightening experience than having a single ECT treatment. So those findings would indicate that for many patients ECT is not frightening, not distressing, but for a significant minority it is. Now obviously that study can be criticised. It can be criticised on the grounds that I, am a psychiatrist, that I have treated some of those patients, that those patients had to come back to the hospital that treated them and tell the psychiatrist about what the side effects from the treatment. It's given some weight by this study. I lent my questionnaire to Jennifer Hughes, who at that time was a medical student in Southampton. She administered it to 72 patients. This was in a general hospital setting, not in a mental hospital, a psychiatric hospital setting. It's at the other end of the United Kingdom in quite a different sort of treatment facility. She was a young girl with no particular status. She had had no treatment contact with any of these patients. She visited the patients at home if they requested that. And these are the sort of results that she found. She found considerable ignorance about the treatment. 72% of patients didn't know what ECT was. 69% didn't know that it included convulsion. And almost exactly the same number, 49%, again said they'd been given no explanation about the treatment. Slightly more patients said they were improved, and slightly more said they would have the treatment again. And it's interesting that nearly half the patients in this study were getting unilateral ECT, and the complaints of memory impairment were not as great. And they would, nearly 3/4 would recommend a friend to have ECT if it was recommended and prescribed by a doctor. So this led some weight to the findings, and again they asked the same question, almost the same figure said that going to a dentist was more frightening than having a course of ECT. So those two studies taken together, I think, add some weight to the findings that ECT is not a particularly frightening or distressing treatment for the majority of patients. I'll briefly mention one or two other studies. This was a study carried out in New Zealand on 178 subjects. These were a group of patients having ECT, a group of visitors to patients having ECT, these were relatives and friends of patients having ECT, and a group of visitors to patients in psychiatric ward who were not being treated by ECT. And the findings that Kerr and his colleagues found were that the further away you were from the ECT experience, the more you relied on anecdote and rumour about what the treatment involved, the more frightening you felt the treatment was going to be, the more apprehensive you were about it, and that the patients themselves had the most positive attitudes towards ECT. The experience of the treatment is something which lessens anxiety and lessens fear rather than heightens it. These are some of the findings. You can see Group 1 are the visitors to non-psychiatric patients, Group 2 are the visitors to psychiatric patients, and Group 3 are the patients themselves. And you can see there is a general trend towards the right side of more positive attitudes towards ECT on those particular statements. This is a study carried out in the States, which sent a questionnaire to over 1,000 individuals, but in fact very few of them were patients. They surveyed professionals, members of the general public, and in those proportions, where only 63 were actual psychiatric patients. They confirmed the findings of Kerr and colleagues in New Zealand, again showing that what seemed to matter was personal experience of the treatment. But the further you were away from the delivery of the treatment, the more negative your attitudes towards that treatment were, and that the most profoundly negative attitudes were in those members of the general public who had no experience of ECT themselves, had no relative who had it, and had only heard about it through the media. The most positive attitudes were of the psychiatric patients themselves and of the psychiatric nurses and residents who had been involved in the delivery of the treatment. So again, this confirms the finding that experience of the treatment, explanation of it by a doctor, and closeness to the actual procedure itself seems to lead to more positive attitudes to it rather than more negative ones. And a final study, the only one which has been carried out entirely on lay individuals, carried out in Dublin 2 years ago, a study which showed remarkable hostility to the treatment, an almost universal finding amongst lay people in the city of Dublin that ECT was dangerous, brain-damaging, frightening treatment, quite in contrast to the experience of patients who have had the treatment. So what can we conclude from these 6 studies which have looked at attitudes to ECT? Firstly, all the systematic studies of patients indicate that the vast majority of patients find the treatment helpful, not frightening, and that they would submit to the treatment again. A small proportion of patients, and I would estimate this from the studies put together, at about 18%, do find the treatment very frightening, particularly the first application. And this fear occurs more frequently in women. That's a consistent finding. In general, patients who have experienced the treatment feel much more positively about it than those who have not, and much more so than members of the general public. There's no evidence that experience of the treatment in itself is aversive. They also indicate that the side effects of the treatment are common, and that memory impairment is by far the distressing side effect, and that this is more distressing when bilateral ECT is used. A further point that I'd like to emphasise, certainly in the UK setting, is that patients place great trust in doctors who are giving ECT, and it's very easy for doctors to abuse that trust. To give you one example, in that study that we carried out, we sent out a letter to patients asking them to come up for interview. We were also looking at the effect of tardive seizures in ECT. Does in fact having an epileptic fit caused by ECT make you more likely to have fits later on? So we wanted to do EEGs on these patients 1 year and 5 years later. 3 patients misread that letter and came up. They had no contact with psychiatry for over a year. They came up having fasted themselves overnight, prepared to have ECT again, just on the say-so of the letter that came to a psychiatrist through the post. And that sort of trust, certainly in the UK setting, is not uncommon, and it places on doctors a great responsibility, I think, not to abuse it. Finally, how can we draw together the findings that I have mentioned today with the accounts that were presented yesterday? It seems to me that there are 4 ways. Firstly, we could say that the patients that I have described are misinformed, they're misrepresenting their state, they're confabulating, as Dr. Bergen yesterday suggested. Whilst this explanation is possible, I think it's unlikely. It's unlikely because of the consistency of the results that these studies find, and because of the openness that the patients did talk about their fears and about memory impairment. Secondly, we could say that the patients were afraid. They didn't want to come and criticise the treatment which they were given. And again, I think the fact that the Hughes study and my study have similar results with quite different doctors would support that view. And finally, we can say that perhaps this experience in the UK is very different to that in America. There are many differences in terms of the amount of private practice, the fact that I would never get any financial reward for prescribing ECT. We are a much less litigious, conscious society, which may in fact make patients' attitudes very different to psychiatry and to ECT in the UK, in New Zealand and Australia than in the United States. I really think that someone in this country systematically asks patients what they think of the treatment. Thank you.
One shock treatment can equal 150 joules of energy. This is equal to dropping a hammer on someone's head from higher than a 5-story building.
At the FDA hearings, the testimony on the reclassification of electroconvulsive devices cited the literature as whether signed or false, typically about 150 joules of energy in a treatment. With the new Thymatron electroconvulsive device, if you check out at 400 volts maximum of 0.9 amps and 320 some millisecond pulses.
Could you finish up your question, your remarks?
Yeah, I would like somebody to tell me. I'm a teacher as well as a physicist, and I brought a kilogram with me. Teachers like to demonstrate. Now, this is a kilogram. It's 2.2 pounds. Heavier than a hammer I used to hit an amp. That I wonder if possibly like Dr. Stein could tell me how high I would have to drop this kilogram from in order to have it hit the ground with 150 joules of energy.
I don't know if that question is in the purview of the panel, but that should be the point. I'd like to go on to the next question.
This is only 10 joules of energy. You're talking about dropping it from higher than a 5-story building. That's physics. Supposedly in pre-med backgrounds.
Thank you.
I never got it.
All right, out with your gun. Out with your gun.
Okay, this won't hurt. It'll be over in just a moment. What's that?
Conductant.
Oh, that will do you. Right, Mr. Jackson.
Open your mouth.
What's that?
This will keep you from biting your tongue.
Well,
Now just bite down on it.
oh.
That's right. Just bite down. Now bite down on it.
Good. Are you ready? Here we go.